Welcome to Dr. V's Pediatric Pulse. Today is a quick review on acquired heart conditions in pediatric care. I will be focusing on two specific diseases. Acquired heart conditions in pediatrics occur after birth and can affect the heart structure and function. There are two common acquired pediatric heart conditions that I will be focusing on: Kawasaki disease and rheumatic heart disease. Kawasaki disease affects children under the age of 6 and is often associated with children under 1 year old. Rheumatic heart, these two conditions often follow an infectious trigger, either viral or bacterial. Therefore, early recognition and intervention are key to preventing long-term complications. Kawasaki disease, as I stated earlier, is common. It is the leading cause of acquired heart disease in the developed world. It affects children under the age of 6 years old with severe disease and often is associated with children under 1 year old. Kawasaki disease is an acute inflammatory condition primarily affecting the blood vessels, the vasculitis, and leading to potential coronary artery aneurysm. The exact etiology is unknown, but may be triggered by a viral or bacterial infection in genetically predisposed children. The age group that is most commonly affected are children under 5 years old with a peak incidence between 18 months and 2 years. Clinical presentation of Kawasaki disease is typically a fever lasting greater than 5 days. And let's remember this acronym, CREAM. So fever plus cream. C is conjunctival injection. Red eyes bilateral without discharge. R for rash, polymorphous maculopapular rash, often in the groin and trunk. E for erythema of the palms and soles, swelling of the hands and feet. A for adenopathy, cervical lymph nodes that are usually greater than 1.5 centimeters. M for mucous membranes, changes in the lips and mouth. We often will see strawberry tongue and dry. Diagnosis for Kawasaki disease is based on the 5 clinical criteria plus a fever lasting at least 5 days. Beware that diagnosis can be made before day 5 of fever if clinical signs are suggestive of Kawasaki. Also, if just 2 to 3 criteria are present, consider an incomplete Kawasaki disease. We also want to look at a laboratory test: elevated ESR or CRP, thrombocytosis, elevated platelets, or elevated liver enzymes. Imaging, echocardiogram should be done to assess for coronary artery involvement. Complications of Kawasaki disease, if we don't diagnose it immediately, can lead to coronary aneurysm, myocarditis, and bleeding due to aspirin. Therefore, consider echo early in the diagnosis. Management of Kawasaki disease, the first line is the intravenous immunoglobulin should be administered within 10 days of the fever onset. Aspirin during the acute phase to reduce inflammation and prevent thrombosis. We need to do a continuous monitoring on this patient. And the prognosis: with prompt treatment, most children recover without long-term heart damage. But some may have coronary aneurysm, which may require long-term follow-up. Again, the key is early diagnosis and early intervention to prevent long-term complications. You can pause the video here and look at this algorithm. You know how much I love algorithm because it helps us visualize the steps that we need to do. So these are steps when you are suspecting Kawasaki disease and how to evaluate and manage it. Rheumatic fever is an inflammatory disease that can affect multiple organ systems, particularly the heart. causing rheumatic heart disease, joints, skin, and the central nervous system. It is a complication of untreated or inadequately treated group A strep throat infection, most commonly seen in kids aged 5 to 15 years of age. Clinical presentation of rheumatic heart fever can be categorized in major criteria and minor criteria. The major criteria we can remember using the Jones acronym. J for joint, migratory arthritis usually affects larger joints like knees and ankles. O for myocarditis, which is an inflammation of the heart, which can lead to valve damage. N is for nodules, which are subcutaneous nodules that are firm, non-tender bumps under the skin. E is for erythema marginatum, which is a distinctive ring-shaped rash. You can see that here at the bottom. S is for Sydenham's chorea, which is an involuntary jerky movement, often affecting the hands and face. Then we have to look at the minor criteria. We can remember that by Cafe Pal. C for increased CRP, A for arthralgia, F for fever, E for elevated ESR, P for prolonged PR interval, A for anamnesis of rheumatism, and L for leukocytosis. Diagnosis for rheumatic heart disease requires two major criteria. That's right here, the Jones, which is the major criteria, or one major and two minor criteria with evidence of a recent group A strep. And then the lab would also include positive throat culture, elevated ASO, and elevated ESR and CRP. Here's a quick chart. To diagnose rheumatic heart fever, you have to have the positive throat culture right here, plus two major criteria, or positive throat culture plus one major criterion and two minor criteria. How do we manage rheumatic heart fever? We treat the underlying strep infection with penicillin or an appropriate antibiotic if they are allergic to penicillin. We also give them anti-inflammatory treatments such as aspirin for arthritis and carditis. We give them corticosteroids for severe carditis. Prophylaxis, long-term antibiotic prophylaxis such as penicillin to prevent future streptococcal infection and prevent recurrent rheumatic fever. We also need to make sure we monitor the cardiac, regular echocardiograms for monitoring heart valve damage. Here's a quick chart to further differentiate the Kawasaki disease versus the rheumatic fever. Look at the differences in etiology, the age group that's primarily affected, and look at the differences in how the cardiac is impacted and the differences in treatments. So both are acquired heart conditions, like I said, and can have serious long-term effects on the pediatric cardiovascular health. Early diagnosis and interventions are critical in preventing complications like coronary artery aneurysm or valve damage in rheumatic fever. And finally, make sure these kids have regular follow-up and monitoring are essentials to ensure the optimal outcomes. So again, this was just a quick review about Kawasaki disease and rheumatic heart disease, which are the two most common acquired congenital heart disease. Please make sure to do your readings. This video is meant as a supplemental information. Stay curious, stay compassionate. This is Dr. V.